Let me ask you a question. What do you think are the two diagnoses that top your problem list when you're caring for the newborn babies in the neonatal unit? Prematurity and respiratory distress syndrome. I hope you agree with me on this. For decades, we have worked so hard through research, recommendations, and guidelines from international bodies to improve the care of these tiny babies and to reduce the morbidity. And we have seen so many advances in the treatment strategies and therapeutic options, and it has shown the results. More and more preterm babies are surviving. Just compare the data from Epicure 1, Epicure 2, and the recent data from Vermont Oxford Network, which was published in Pediatrics. The Epicure 1 and Epicure 2 were the big research data from 1995 and 2006. The data shows that the survival figures for babies between 24 and 26 weeks have more than doubled. And that's a remarkable achievement indeed. But what about the lung injury and its consequences, which is bronchopulmonary dysplasia? Sadly, these numbers have continued to remain high at 60%. Clearly, we are winning on survival, but we are not winning on the battle on reducing the lung injury and its consequences, such as bronchopulmonary dysplasia in these tiny babies. So, this battle continues and is a constant source of research, recommendations, and change in practice. And recently, we've had a wave of new guidelines from different organizations. The NRP 9th edition talks about the delivery room practices for all newborns, but also focuses on preterm babies. And then you have the British Association of Perinatal Medicine, which published a guidance recently on the management of extreme preterm babies in general. But again, it talks about certain aspects of care in relation to respiratory distress syndrome. But the most important one is the European Consensus Guidelines on the management of respiratory distress syndrome in preterm babies. In fact, the European Consensus Guideline has been in existence for more than 15 years now and is being updated every 3 years. And there have been many iterations of this. In this video, I'm going to take you through the latest updates on the management of RDS, primarily from European Consensus Guidelines and also the evidence behind them. We'll also look at how they connect with guidelines from other organizations, as I mentioned earlier, and where they agree and where they diverge. And more importantly, how can we apply these at the bedside? Welcome to Tinytaught, a channel where we discuss various aspects of neonatal care that matter to healthcare providers who care for the tiniest of the babies. My name is Dr. Shivashankar and I'm a neonatologist. So let's begin. Before we dive in, let's make sure that we are all reading from the same map, and that is the grading of evidence. Each recommendation we discuss has two components. One is the quality of evidence, other one is the strength of recommendation. Now, the quality of evidence is graded from A to D, A being high certainty to D being the very low certainty. And then you have the strength of recommendation, which is scored either 1 or 2. 1 for strong recommendation and 2 for conditional recommendation. So A1 is the gold standard, which is a high certainty evidence with strong recommendation, whereas D2 is at the other end of the spectrum, very low certainty and a conditional recommendation. Think of it as the difference between A1 being the we know this works to D2 being we think this might help, but don't bet everything on it. So let's keep this framework in mind as we go through this video, because the grade of recommendation often tells you as much as the recommendation itself. Okay, before we even think about what happens in the delivery room or in the neonatal unit, we have to ask the most fundamental question of all. How do we give these babies the best possible start even before they are born? Let's look at this data which is presented in the European Consensus Guidance. This data is about the percentage of babies who received surfactant and mechanical ventilation at different gestational age groups, from 24 to 26 all the way down to 32 weeks. And these figures start from 90% for 24 to 26 weeks, and they drop down to somewhere between 25 to 32%. And this drop is in just about 6 weeks of intrauterine life. And that is how much difference an intrauterine milieu makes for these tiny babies in terms of organ maturation, lung development, and growth. And it just means that keeping them in the uterus for as long as possible safely is the best strategy. And these fundamentals haven't changed at all over the years. And they don't need to, because the evidence behind them is quite solid. And they are good antenatal care, reducing teenage pregnancies, and ensuring that there is appropriate space between the pregnancies, and to avoid unnecessary cesarean sections, and to make sure that we screen the mothers for maternal conditions such as preeclampsia and treat them appropriately. So we know this and we do make all the efforts to make this happen. But it's not always possible to prevent a preterm delivery, right? So when the preterm delivery becomes likely, then what do? We need to think of three pillars of optimization. The first pillar is the place of delivery, and the evidence on this is quite clear. Babies below 28 to 30 week gestational age should be born in a center with a co-located tertiary neonatal unit. It's the right team, right skill, and the right equipment, all in the same building at the same time. And that's a requirement. Now, the second pillar is antenatal steroids. If there is one intervention in the perinatal medicine that comes closest to being universally accepted, it is the antenatal steroids. The core recommendation remains what it has always been, and that is to give antenatal steroids for any woman at risk of delivering before 30 weeks, ideally giving the lungs at least 24 hours to respond before birth. And this window is the goal of that 24 hours. And the evidence and the grade is A1. There's no debate on this. But the edges of that recommendation are where it gets interesting. Take viability, for example. The goalposts are constantly moving with regards to viability and is currently sitting between 22 and 23 weeks. And the data in this gestational age group shows that more and more babies are surviving at this gestational age. But here is the problem. Most of the landmark studies on antenatal steroids were done in babies above 24 weeks. So what happens at 22 and 23 weeks? We often say there's no evidence, but that's not quite right. There is no RCT evidence, yes, because these gestational age groups were excluded from the trials. But we do have observational studies published in recent times that do suggest that antenatal steroids are beneficial in this age group too. And the British Association of Perinatal Medicine, in their recommendation recently, is explicit about it. And that is, if the decision is to provide survival focused care, then these babies should receive antenatal steroids. Now, let's look at the other extreme, which is 34 to 37 weeks. And here the consensus has shifted. The concern about hypoglycemia now outweighs the benefit of lung maturation, so antenatal steroids are not recommended here. So the next question is, what's the ideal time for giving antenatal steroids? The ideal window is 24 hours to 7 days before delivery. Less than 24 hours before delivery is not ideal, but if a woman presents in threatened preterm labor, it is sensible to give steroids even if she delivers before that 24-hour mark. Some benefit is always better than none, isn't it? But if you have given the antenatal steroids and she doesn't deliver in the next 7 to 10 days, what happens then? Beyond 7 to 10 days, the efficacy starts to diminish. And this is where a real clinical challenge emerges, because you cannot time preterm labor very well, can you? Look at this data. Nearly 40% of women who receive antenatal steroids for threatened preterm delivery actually go on to deliver at full term. And in those cases, you have taken the risks of antenatal steroids without getting the intended benefits. So you have actually increased the net risk. So the question becomes, how do you actually identify which women are truly going to deliver in the next 7 to 10 days? And this is where the biomarkers and the estimation of cervical length become genuinely important. It needs to be used to identify who are likely to deliver so that you can target these antenatal steroids where they will actually make a difference. Now, finally, in this section, is there anything new on the horizon for antenatal steroids? There was a publication in 2022 by Schmitz and the team in the Lancet, and they asked a provocative question: are we giving too much betamethasone? So they compared two doses, half the standard dose versus full standard recommendation. And what they found was interesting. Between the two groups, there was no difference in the BPD or mortality, and there was only a slight increase in the need for surfactant from 17.5% to 20%. And that's it. No major difference otherwise. And this raises a genuinely important question. If half the dose gives you almost the same benefit, could it also come with less risk? And this is a space worth watching for any future studies and evidence. Now let's look at the third pillar, and that is neuroprotection and the use of magnesium sulphate. Below 32 weeks, magnesium sulphate reduces cerebral palsy by 30% by the age of 2 years. So it remains an A1 recommendation. And one of the most important practical points in this is magnesium sulphate works even when given just 4 hours before delivery, which means that even a woman with advanced cervical dilatation should receive it. So late presentation is not a reason to withhold magnesium sulphate. So from the practical application of these guidances point of view, if a pregnant mother presents in a threatened preterm delivery and if she is less than 28 to 30 week gestation and has presented to a maternity unit without a co-located tertiary neonatal unit, assess her for cervical length and do biomarker measurements to get an idea of if she is likely to deliver in the next 7 to 10 days. And this is a grade B2 recommendation. And if it is confirmed, then it is best practice to transfer her to a perinatal center who has experience in the management of respiratory distress syndrome if it is safe to do so. And it's a grade B1 recommendation. Then give a single course of antenatal corticosteroids if the pregnant mother is less than 34 weeks of completed gestational age, and this is a grade A1 recommendation. And also administer magnesium sulphate if she is less than 32 week gestation. And as we talked about, this is also a grade A1 recommendation. Okay, now the pregnant mother is in advanced labor and is likely to deliver soon. What does the latest guidance say with regards to how do we manage in the delivery room? And I'll go through the important changes in the recommendation and compare it with NRP 9th edition guidance. I won't go into the details of NRP 9th edition guidance or the details, every detail of the European Consensus Guideline. We can do that in detail in another video. But the most important change is how much oxygen should we start with during resuscitation of preterm babies. The European Consensus Guideline now recommends that babies below 29 weeks, the initial starting oxygen should be 60%. In fact, the same guideline from 2022 recommended to start at 30%, and it's a significant jump. But here is the thing. The NRP 9th edition takes a slightly different approach. It recommends starting at 30% for all babies below 32 weeks and titrating the oxygen concentration based on saturations. Now, the NRP guidance covers all babies below 32 weeks, which means it includes even those at 29 weeks and below. Same gestational age groups, but different starting points from the two recommendations. And the European Consensus Guideline looked at two key pieces of evidence for this recommendation. The first one was Torpedo 3060 trial, which was published in JAMA in late 2025. They looked at the babies between 23 to 28 week gestation, and they were randomized into two groups. One group was receiving oxygen at 60%, other one receiving oxygen at 30% in the delivery room. The primary outcome was major brain injury or death at 36 week corrected gestational age. And interestingly, it showed no difference between the groups. But the secondary outcome showed some difference between the two groups. For example, babies who received 60% oxygen were less likely to need cardiac compression, less likely to need epinephrine, and more likely to reach the target saturation of 80% by 5 minutes. And that is clinically meaningful, even though the primary outcome was not different. And the second piece of evidence comes from a systematic review published in JAMA in 2024. In this analysis, they pooled the data from just over 1,000 babies born under 32 weeks from multiple RCTs and compared resuscitation of babies in 3 different initial oxygen concentration. The first group was babies who received high initial oxygen concentration of more than 90%. And the second group was the intermediate at 50 to 65%. And the third group was low oxygen concentration of 30% during resuscitation. And the results were interesting. Resuscitation with high initial oxygen concentration of more than 90% was clearly better and associated with significantly reduced mortality compared to low oxygen at 30%. But the level of evidence was of low certainty because, as you can see, the confidence interval was quite wide. Then they compared the 90% with the intermediate oxygen, which is 50 to 65%. Now, the high oxygen still appeared to do better in terms of outcome, but here the level of evidence was very low certainty, suggesting that it was a very weak evidence. And as you can see, the confidence interval here is very wide, that is between 0.11 to 0.99, and it's very close to touching the midline at 1. So the way they interpret these results is that there is not much difference between the intermediate and high oxygen. Yes, the evidence is not very straightforward, but you can see the rationale for the recommendation. Now, when you look at both NRP and European Consensus Guideline, how do you reconcile in clinical practice? In my view, the best thing to do is to have your unit guideline based on one particular recommendation and just stick to it. One thing is clear though, both the guidelines are aligned in principle but slightly different in practice. Both recognize that you need to titrate oxygen upwards as needed during resuscitation. The disagreement is simply about the starting point, 30% versus 60% for extreme preterm babies. And also, what both agree on is the target to be achieved, saturation of 80% or more and heart rate of above 100 by 5 minutes of age, because this is associated with better outcomes at 2 years. And that's our goal. And with regards to using initial concentration for the rest of the gestational age group, the European Consensus Guideline recommends starting at 30% for babies between 29 to 31 week gestational age and room air for babies more than 32-week gestational age. The second important difference from the previous guidance is delayed cord clamping. And delayed cord clamping is not news hot off the press anymore. The evidence has been building for years. And there is significant benefit from delayed cord clamping both for term and preterm babies. And in fact, both NRP and European Consensus Guideline recommend it up to 60 seconds. But the 2025 European Consensus Guideline goes even further. They introduce a conceptual shift from time-based cord clamping to physiology-based cord clamping for babies less than 34 weeks. So instead of watching a clock, you watch the baby. You clamp the cord when the baby has achieved respiratory stability, not because 60 seconds have passed. And this is an A1 recommendation, and that's interesting. And it's a strong statement. And how have they arrived at this conclusion? It is based on ABC3 trial published in Lancet Regional Health in December 2024. In this randomized controlled trial, they compared the physiology-based cord clamping against time-based clamping in babies born below 30-week gestation. And what they found was no difference in survival between the two groups. But the subgroup analysis revealed some meaningful advantages to physiology-based clamping. There were fewer red cell transfusions, there was lower incidence of late onset sepsis, and more importantly, parents were less anxious and more content with physiology-based cord clamping. But it's not that easy from the practical implementation point of view, isn't it? Physiology-based cord clamping requires the right equipment, right training, infrastructure, and not every unit can do this yet. And one more thing, when delayed cord clamping isn't feasible at all, both the European Consensus Guideline and the NRP agree that umbilical cord milking should be considered only about 28 weeks. Below 28 weeks, cord milking is not recommended for the fear of intraventricular hemorrhage. And another important change in the latest guideline is regarding the tools that are used for intubation in the delivery room. The general direction of travel here are well established. Avoid intubation where possible, especially in babies above 24 weeks. But what's new in the recommendation is the routine use of calorimetric carbon dioxide detectors in the delivery suite and also the use of video laryngoscopy during resuscitation. And the recommendations are strengthening, and if you have the equipment and the training, these should be part of your standard approach. Okay, we have resuscitated the baby based on their gestational age and the recommendations, and we have brought the baby to the neonatal unit. Now, how do we manage them in the neonatal unit, and what are the newer recommendations in managing these babies? Let's look at that in the next section. Okay, first let's look at the saturation targets. And if there's one area of neonatal care that illustrates how just difficult this work is, it is the saturation targeting. We've been studying it for decades, and we still do not have a fully satisfying answer. The current gold standard remains the NEOPROM data. The NEOPROM showed that lower saturation targets between 85 to 89%, while they did reduce the ROP rates, but the price was steep with higher mortality and more NEC. So that trade-off made the decision quite straightforward. So the current standard is to target the higher range between 91 to 95%. But are we certain this is the final target that has been established to achieve? Now, a recent retrospective cohort study published in Neonatology in 2025 tries to challenge this assumption. They looked at preterm babies less than 29 weeks born between 2011 to 2018, and they compared two saturation groups. One was the intermediate saturation targets of 88 to 93, and the other one was the higher target group of 90 to 95%. And interestingly, survival without morbidity was actually higher in the intermediate target group. In other words, 88 to 93% may actually be preferable to 90 to 95% with similar mortality, similar ROP risk, but better overall outcome. And those of us who have been in this field for a while may remember that that was the saturation target that we used to use many years ago. So the debate is not over yet, but this is an area to watch closely. But what's important to remember is that the current standard is still based on the neoprom data, and the saturation target is between 91 to 95%. So the baby is in the neonatal unit. We have set the saturation targets, and this baby is on CPAP. And we know that the respiratory distress syndrome does get worse over the next few hours, and the baby is likely to require surfactant, of course, depending on the gestational age and the surfactant deficiency. So, two critical questions that come to mind, which the guidance from European Consensus Guideline tries to solve. The first one is which baby should receive surfactant? And the second one is how should we give it? This is probably one of the most important and rapidly evolving areas in RDS management. Surfactant therapy works, we know that. It improves survival, reduces ventilation requirements, reduces pneumothorax risk, improves saturations, cuts oxygen requirement, and the science is not in question. The question is, how should we give it? So let's tackle the second question first. How should we give it? Let's go to the timeline on the evolution of administration of surfactant over the few decades. We started where you might expect, and that is intubate, give surfactant through the ET tube, continue mechanical ventilation until the baby is ready for extubation. Effective, but costly in terms of lung injury due to the mechanical ventilation for prolonged periods of time. Then came INSURE, which is intubate, give a bolus surfactant through the ET tube, bag a few times, and then either extubate immediately or within a very short period. Clearly a step forward, and it proved its worth in reducing lung injury. And then came LISA, which is less invasive surfactant administration. It's using a thin catheter inserted directly into the trachea while the baby is continuing to breathe on CPAP spontaneously. Surfactant delivered in small aliquots, no bagging, no forced lung opening. And the evidence is compelling. Many studies and systematic reviews have demonstrated significant benefit of LISA over both INSURE and also conventional intubation and ventilation, and they are decreased risk of composite outcome of death or BPD at 36 weeks, reduced need for intubation at 72 hours, reduced risk of severe intraventricular hemorrhage, and BPD among survivors. And let me also talk about one of the largest RCTs in this space, and that is the Optimist A trial. They had a total of 485 babies between 25 to 28 week gestation, and they were randomized to LISA or sham procedure at an oxygen threshold of 30%. And the primary outcome was death or BPD. And interestingly, it did not reach significance. But when they looked at the BPD in survivors, the difference was quite clear. It was 37% in LISA group versus 45% in the control group. And at 2 years, LISA group had fewer respiratory problems. There are question marks about this study, but what's important to know is that many more studies and meta-analysis have proven that the LISA is beneficial over other methods of administration. For example, the trial by Anup Kataria and his team brought all of this together powerfully, where they combined early CPAP with early surfactant with LISA and early caffeine in babies between 24 to 29 week gestational age with RDS. And when they compared it with only early CPAP and early caffeine, the respiratory failure came down from 53 to just 23% in the intervention group, nearly half the rate. So LISA is no longer experimental, it is the recommended approach. There are still some unanswered questions. For example, for LISA, you still need a laryngoscope and the procedure can be uncomfortable. And if you use sedation, there's a risk of post-procedure apnea requiring positive pressure ventilation, which is what we are trying to avoid when we're using LISA. But there are limited studies so far which show that there is no clear benefit from either sucrose or sedation on the ease of procedure. So we'll have to wait and see. And the other delivery methods are also being explored. For example, the use of laryngeal masks or aerosolized surfactant. In fact, a large multinational randomized control trial is currently comparing laryngeal mask surfactant to routine care in over 900 preterm babies. So watch this space. And the next question is, how do you decide when we should give surfactant? To understand this better, let's group the babies into three groups. The first group is below 24 weeks, and these are the most extreme, and CPAP alone is most likely not going to be enough. So invariably we end up intubating the baby in the delivery room, and we are going to give surfactant as soon as possible, either immediately in the delivery room or as soon as they arrive in the neonatal unit. Then comes the second group, that is the babies between 24 to 30 week gestation who needed intubation for stabilization at birth. In this group, you give surfactant as soon as possible to improve the compliance and then aim to extubate as quickly as you can. And the third group is where it gets interesting, and that is babies who are above 24 weeks who have successfully transitioned onto CPAP but in whom RDS is likely to develop and progress over the next few hours. And these are the babies where a decision needs to be made as to when to give surfactant. And how do you decide? Now, traditionally, we relied on oxygen requirement, work of breathing, saturations, blood gas results. And the 2022 European Consensus Guidelines set the threshold to give surfactant at an oxygen requirement of more than 30%. But the field has moved. And the focus is moving from just the oxygen requirement to lung ultrasound scan within 2 hours of age, and it turns out to be quite a remarkably reliable tool. In fact, this meta-analysis by Capasso and the colleagues, they looked at the accuracy of lung ultrasound scores in over 700 babies in predicting the need for surfactant. And it showed excellent results from sensitivity, specificity, positive and negative predictive value, all above 0.8. So in this group of babies, you do a lung ultrasound scan and do the scoring and then decide on giving surfactant. Now, there are some more studies which have been done which haven't proved as useful, and that is using budesonide with surfactant. Two randomized controlled trials, the PLUS trial by Manley, published in JAMA 2024, and BIP trial by Ambavalan, published in JAMA 2025, both have conclusively shown that adding budesonide to surfactant does not prevent BPD. So the question now is settled. There's no point in mixing budesonide with surfactant. So the most important takeaway from this section is, do not bag the baby, stabilize with CPAP, give early caffeine, perform lung ultrasound scan within 2 hours of life to guide the surfactant decision, and then give surfactant via LISA. Okay, so far it's quite clear that we need to try and avoid mechanical ventilation if possible, and we used non-invasive respiratory support in two scenarios. The first one are a primary support where they get put on straight away without intubation, and the second one is where we use them to support the baby post-extubation. And there are different types of non-invasive respiratory supports available. How does each type of non-invasive respiratory support fit into our practice, and what's the evidence behind them? Let's look at it. Now, CPAP is the first one. It's the first line of respiratory support introduced for the first time in 1993 by Jacobson et al. And they called it the mini touch treatment for very low birth weight infants. A simple idea, but a powerful one. Then the COIN trial came in 2008, and it delivered the evidence that babies did not need to be intubated and ventilated. They could be managed on CPAP, and that was a landmark. And we all know how good CPAP is. It improves functional residual capacity, reduces work of breathing, cuts oxygen requirement, and reduces apnea. And CPAP is the mainstay of non-invasive respiratory support. And how do you provide CPAP? You use two different interfaces, either nasal masks or binasal prongs. Both have been shown to work. One of the important risks of using them is the nasal injury, and for this reason we rotate between masks and the binasal prongs to reduce that risk of nasal injury. Interestingly, though, some studies do suggest that rotation may not actually be superior to using mask alone. As far as the machines, as we all know, there are different types of CPAP machines: dedicated CPAP machines, ventilator based CPAP machines, and bubble CPAPs. It appears that there is no particular advantage of one over the other. So use what works in your unit. And beyond CPAP, what else do we have? Let's start with BiPAP or DuoPAP, and they use lower inspiratory pressures of around 10 to 12 centimeters of water on top of PEEP. The evidence has shown that they are not superior to CPAP, so there's no point in using them. But NIPPV is a different story compared to DuoPAP. When we say NIPPV, we are talking about pressures similar to what we would use on a ventilated baby with an ET tube, just delivered through a nasal interface instead. So is NIPPV better than CPAP? And the evidence is more encouraging. In fact, a recent systematic review showed that NIPPV was superior to CPAP in reducing the need for intubation with a relative risk of 0.67, and even the confidence interval is quite narrow. And on BPD, NIPPV is known to reduce it, especially when synchronization is used. But then this is important. The confidence intervals are very wide and approaching 1. So take this result with a degree of caution, and note that most of the babies studied were between 28 to 32 weeks. Now the other device is high flow nasal cannula oxygen. Can it be used as a primary support? When compared directly to CPAP, it is not as effective and has a higher rate of treatment failure as a primary support. But it has a role to play in weaning and in reducing nasal discomfort, but it's not your first line choice. Now there's a new kid on the block, and that is nasal high frequency ventilation. The Cochrane review from 2024 showed that the nasal HFOV as primary support reduced intubation, reduced reintubation following extubation, and even reduced the risk of BPD. I don't see many units using this nasal HFOV, but this probably is an area that will be explored further in the coming months and years. And these are all primary support. What about following extubation, and how do they perform if you're using it after extubation? The picture is similar. NIPPV outperforms CPAP, but here is the question worth asking. Is NIPPV better because of synchronization and pressure delivery, or simply because you are using a higher mean airway pressure? The LCAT study tackled this question. They compared higher CPAP pressure of 9 to 11 centimeters against lower pressure of 6 to 8 centimeters following extubation. And the higher pressures led to significantly less reintubation within 7 days, which suggests that it may not be the synchronization that drives the NIPPV advantage. It may simply be the higher mean airway pressure. So there is still an option to use CPAP at higher pressures if you don't want to use NIPPV. And finally, in this section, NAVA deserves a mention. Its great advantage is synchronization, because it uses diaphragmatic electrical activity to trigger the respiratory support, so the ventilator breathes with the baby rather than at it. Unfortunately, studies have not shown NAVA to be superior to CPAP as a primary mode in preterm babies, but it has shown benefit following extubation. More than this, the main barriers remain practical application. That is the cost of NAVA catheters, which is quite high for it to be repeatedly used over a long period of time. And then the non-availability of NAVA on different ventilator machine platforms, that's an issue. So when you have a baby in the neonatal unit transferred from the delivery suite on CPAP, how do you proceed with the current recommendation? First, put them on either nasal CPAP at 6 to 8 centimeters or NIPPV as a primary mode of support, and perhaps NIPP is preferred over CPAP. Don't use BiPAP or DuoPAP, and use nasal cannula oxygen while weaning the baby off the respiratory support, and don't use it as a primary support. And finally, we come to situations where unfortunately we cannot avoid mechanical ventilation, either because these are extreme preterm babies below 24 weeks, or even those who are above 24 weeks who do not tolerate non-invasive respiratory support. In this area, the recommendations have not changed a lot in recent times. The key points still remain, and those are volume targeted ventilation with tidal volumes between 5 to 7 ml per kg. HFOV has not shown to be superior to volume controlled ventilation. However, compared to conventional pressure controlled ventilation, it is considered superior. And then use caffeine, allow permissive hypercapnia, target extubation when the MAP reaches 7 to 8 centimeters of water, and the recommendations are still intact on this. Finally, we have babies stuck on the ventilator for longer periods of time and unable to either wean or extubate, and this is where postnatal steroids are quite useful. In fact, the story of postnatal steroids in neonatology is in many ways a cautionary tale of how quickly practice can swing and how long it takes to reconcile and recalibrate. We now know that the BPD and the postnatal steroids independently increase the risk of neurodevelopmental problem in preterm babies. So the question is not whether there is a risk, but the question is which risk is greater and when. And the current evidence is this. In the first week of life, harmful effects of postnatal steroids outweigh the benefits, whereas beyond 7 days, the calculation shifts and so are the risks. And with time, the neurodevelopmental risks posed by the ongoing BPD becomes greater than the risk posed by the postnatal steroid itself. And in fact, this is an interesting paper by Jensen et al., who quantified the risk of neurodevelopmental outcomes due to postnatal steroids against the BPD itself in a way that is quite useful at the bedside. And that is, for every 10% rise in the baby's BPD risk, the neurodevelopmental harm attributable to steroids falls by about 3%. And the calculation tell you that where steroids start doing more good than harm is when the neurodevelopmental risk due to BPD reaches 60%. So if you're looking at a baby who is more than 1 week old and whose calculated BPD risk is 60% or above, the evidence supports introducing postnatal steroids. And what about supportive care? They're all important in making sure that the baby's overall care is up to standards, and the pillars of supportive care have not changed. And their consistency is itself a signal that we've got these right. The good temperature control, appropriate use of antibiotics, good nutritional support from early on, careful monitoring of blood pressure, perfusion with targeted management, etc. These are not glamorous recommendations, but they're the scaffolding on which everything else we do is built. Get them right, and all the sophisticated interventions we have discussed have a better chance of working. A lot has moved, but the common thread through all of it is the same question we have always been asking. How do we give these tiny babies the best possible chance while protecting their lungs and their brains along the way? We don't have all the answers yet, but we're getting closer. Thanks for watching. If you found this useful, give it a like and consider subscribing. See you in the next video.